organized by Department of PG Studies in Panchakarma, JSS Ayurveda Medical College, Mysuru. Last week, we had discussion with Dr. Shyam Krishnan, who enlightened us with case series on degenerative disc disease and juvenile arthritis and their management. Today, we have another eminent speaker, Dr. Sachin Sir, Professor and Head, Department of Panchakarma, Sri Ayurveda Mahavidyalaya, Nagpur, Maharashtra. It's my pleasure to have introduced Dr. Chandalia Sachin Sir. Hails from Nasik. He completed his BMS from Bharati Vidyapita College of Ayurveda, Pune, post-graduation MD in Panchakarma from IPGT Jamnagar, Gujarat Ayurveda University. Sir is pursuing his PhD from Datta Mege Institute of Medical Science, Wardha, and presently working as a professor and head, Department of Panchakarma, Sri Ayurveda Mahavidyalaya, Nagpur. Sir has a teaching experience for UG students for more than 17 years and has for BG scholars for about 10 years. He also delivered lectures about Ayurveda in Germany. Sir has secured gold medal from Institute of Indian Medicine, Pune, for the thesis work, a clinical study on standardization of Vamana process with special reference to Alpiki, Vaigiki, Maniki, Laingiki criteria in 2004. He has also been awarded with Ranade Puraskara for an article published in Ayurveda Patrika, Nasik in 2015, and also been awarded as Utkrishta Shikshaka Award for the year of 2017-18 by Sri Ayurveda Mahavidyalaya, Nagpur. Sir is working as a member of Board of Studies in Maharashtra University of Health Science. Sir is also enlightening the Ayurveda fraternity with his books. He has published 4 books in the field of Panchakarma. Sir has been a part of various research projects submitted to Maharashtra University of Health Science. He has so far published more than 40 articles in various national and international journals. Sir has guided more than 10 postgraduate students and also participated as a resource person and has done paper presentation in various national and international seminars and workshops. JSS Ayurveda Medical College had a privilege to have Dr. Chandalia Sachin Sir for the CME in 2018, where he demonstrated a live from Vamana procedure. He was also been a part of symposium conducted by IPGT RA Jamnagar and Ayurveda Vidyapita Nagpur. Sir, we are happy to have you and hear from you today. I once again welcome you on behalf of institution. Now I request Dr. Sachin Sir to take over the session. Thank you. Over to you, sir.
Thank you all. Am I audible?
Yes, sir,
Hello.
you're audible.
Okay. Thank you. Thank you, JSS Ayurveda Medical College and the Department of Panchakarma for inviting me as a guest speaker regarding your case series, which is continuously going on since 2 months. So today I'm honored to present this guest lecture on sensory motor polyneuropathy. Am I audible, sir? Exactly.
Yes, sir,
Hello.
you're audible.
Okay. So today we are going to discuss a case which was admitted in our hospital 2 years back, as it was a grave case, and patient came to us on a stretcher, and she was absolutely in no condition, having no hope of life, as per her fear also, and regarding her health condition also. So and she stopped all the modern medications when she arrived at her hospital. So we took that case and solved that case successfully. So today we are going to discuss that case. I'm going to discuss that case with all of you. So I will start the case immediately because we have a lot of things to discuss. So the patient was 36-year-old female, and she was the resident of Nagpur itself. She came at her hospital on 29th of April 2019, and she was in a hospital till the 15th of June 2019. This was the first OPD paper, OPD sheet.
Sorry to interrupt.
Yeah.
Are you displaying a PPT, sir?
Yeah. Yeah. Is it not visible?
No, sir, it is not. You haven't shared the screen, I feel, sir.
Okay. Just a second. Just a second, sir. Share.
Yes, sir.
Okay.
Now it is visible. Now it is visible.
Thank you, sir. So
Thank
we are discussing the case of demyelinating sensory motor neuropathy. So the patient was 36-year-old female patient, and she was the resident of Nagpur itself. And she got admitted in hospital on 29th of April 2019 and got discharged on 15th June 2019. This is the first day of her case paper, and she was having a lot of complaints and all those things. So we suggested her to get admitted. So initially, when she came to our hospital, she was having weakness in both upper limbs and lower limbs. Then, along with that, kriya hani, muscle power was very less. Ubhay Hastapada Gaurav, Chimchimayan, Ubhay Hastapad Chimchimayan, tingling numbness was there, and she was having tingling around the lips also. Then she was having pain all over the body, specifically in both the arms, both legs. Then Katishula Prushtashula was also there, and she was having tenderness at some places. Then she was having giddiness, and on face examination, she was unable to form any wrinkles, and she was unable to create a puff, and smiling was also absent. She was continuously having sputum in her mouth. She was Nishtivan was repeatedly, and swar was very kshina. Uh, Along with that, when she got admitted, Tivra Kshudamandi was there, and Malapravati was irregular and having no sensation of the passage of Mala if it happens. When admitted, she was having loss of bowel control, and she was not aware of her bowels also. So this is the discharge card when she got admitted from this hospital. This is Government Medical College, Nagpur, and you can see she was admitted over there for almost 15 days, and this was the diagnosis: demyelinating sensory motor polyneuropathy with bulbar involvement. These were the findings of that patient. Nancy was done, sensory motor polyneuropathy was there, and she was given all the treatment at GMC. You can see the line of treatment also here: injection immunoglobulin and some painkillers, NSAIDs were there. So these were the findings. So, and the neurophysician was having the chief complaint of the GBS also was there. So history of the present complaints. Initially, around 4th of April, the patient got temperature and severe weakness along with the nausea and a few episodes of vomiting along with that. As per local guidance of her relatives and all those, they thought it is a pilia, and they took some medications from the quack. They wasted 2 to 3 days in doing those medications, and then somebody suggested them to go to GMC. Then GMC referred to them again neurophysician, where she got NCV, and the diagnosis was the sensory motor polyneuropathy. Then she got admitted in the GMC, but in GMC she got treated with the immunoglobulins, but there was no improvement. No physical conditions was improved. Mobility was not achieved, and after 15 days of treatment, the treatment was getting costlier, and so she was advised to go home, and no assurance was given regarding the prognosis. Plasmapheresis or immunoglobulin therapy was suggested. They took it for initial 2 to 3 days, 5 days, but it was not possible for them to continue that. So they were discharged with Rylstubin C2, DBT prophylaxis, bilateral crepe bandage for the both lower limbs, and her condition was so bad that it was said to her that the condition might be continued for next few weeks or months, or it cannot be said that she can have the date within 15 days to 1 month also. It was so severe, and they asked her to keep an eye over breath count, single breath count, so that everybody knows that it is meant to, it is a parameter for the putting the patient on a mechanical ventilator. So single breath count is the patient. We ask the patient to count out louder after maximal inspiration. Ability to reach 15 days is the normal respiratory function. So single breath count of less than 15 typically correlates with the low forced vital capacity and respiratory muscle weakness. It is a predictor value for assessing the requirement of the mechanical ventilation in patients with Guillain-Barré syndrome. So after 15 days of the treatment at GMC, the patient was completely debilitated, was immobile and bedridden, and had severe weakness in both her limbs, getting feedback from the right tubes due to lack of assurance from neurology department. And regarding further better prognosis and having an idea of possible death as complication due to the respiratory failure, she arrived at Pakwasa Samanvay Rugnalaya, that's our hospital, as a last hope from the Ayurveda. Somebody suggested that this hospital is well known for treating the neurological musculoskeletal patients. So she arrived at our hospital. So before that, I would like to share a video of the patient. One second. Hold on, please. My screen is visible, sir.
Yes, sir, it is visible, sir. Yes, sir, visible, sir.
So this was the patient on the day of admission. So the investigations which were done at the GMC were total protein 7.9, bilirubin 0.6, creatine 0.6. Electrolytes were within normal range, and vitamin B12 was also ruled out. So 1687 was the value. Sugar was in a normal condition. ESR was raised in that patient. Other systemic examinations were done. 120 by 82 was the blood pressure. Heart sounds were normal. ECG was previously done. It was normal. Respiratory rate was slightly tachycardia, just from the on the initial day. Liver was not palpable. Spleen was not palpable. Clinical examination, we carried out all the clinical examinations with all the scales. The cranial nerve examination, all the examinations were normal. Mental status was normal. So no neuropsychiatric involvement was found in the patient. Regarding the sensor examination, tingling sensation around the lip region was present. Both the upper limbs, the senses in the sensory or touch perception in both the upper limbs were present as normal, and in both the lower limbs, it was they were present, but slightly laser sensation was there, and particularly right hip to knee region, it was absent. So involvement of Sparshanendriya, damage of Sparshanendriya by the provocated vata, that is vata prakopa, this is in assessing the prana vata. So, okay. So this is the examination which we carry out at this is the patraka. This is mental status, consciousness. She was well oriented, conscious, no delusion, hallucination, and delirium was present. Speech was normal. though Swara Hani was there, but speech was normal. And all the examination were carried out, olfactory, optic, oculometer, trochlear, trigeminal, all the cranial examination were carried out and they were normal. And this is the sensory examination which was carried out. This is, you can see the right upper limb, right thigh on the leg, right side, it was absent, right? And left side, it was present. So muscle power grade, an upper limb 3/5 and 3/5 was there. Just she was able to hold the hand on her own, but and not able to uh, bear the any resistance. And lower limb, the power was absolutely lesser. It was just 2. So bal of Vayu, Vayu balam Vayu data sharirnam. So I always ask the patient, in the Vatvedi patient, to I always check the strength of the Vayu. Strength of the Vayu and bal of the Vayu and bal of Kapha. Kapha indicates the bulk of the dhatus, and Vayu indicates the bala of the action. So in this patient, ball of the Y was lacking. The strength to stimulate the muscles, nerve and joints is lacking over here. In Pakshavada, we can see when Vata gets vitiated, all muscles, snayus and sandhis are present, but the movement is, the patient is unable to move the hand. That is the lacking of the strength of the Vayu. So muscles and bulk of the muscles are present, but inability to their functioning is indicated by the lack of the strength of the Vayu. So Vayu, Ayu, Balam Vayu. So bal of the Vayu was lesser in this patient. Then muscle power grade, you can see 3, 3, 2 and 4, 4. Upper limb 4, 4, 2. Little resistance was there. And lower limbs, it was just 3, 3 and 2, 2. Reflexes, it was typical reflexia in all the categories. Biceps were absent, triceps were absent, brachioradialis was absent, knee absent, plantar was slightly present, and corneal was normal, and abdominal was slightly diminished. So plantar and abdominal were diminished, ankle was absent, but all the other deep tendon reflexes were absent. It's areflexia in the Guillain-Barré syndrome, typical Guillain-Barré syndrome. So reflexes are the result of the synergetic quick action of Vyana in company with the prana. The sensory perception is carried out quickly by prana, and motor reflexes responded quickly by Vyana. So it is the cohesive action of the Vyana and prana. This is the reflexes which we just discussed, were present on 29th, 4/29, and all were just triceps reflex in the right side was slightly developed after 15 days of the treatment. This is the Barthel index, which we generally carry out in all the hemiplegic or neurological patients. This is the index of the 10 points in which the feeding, bathing, grooming, dressing, bowels, bladder, then toilet use, transfers of the patient from one place to another, the mobility of the patient, and stair climbing is checked, and they are counted on 0, 5, 10. You can see the score as 0 unable, 5 needs help cutting or needs some help, and 10 is independent. So this is the patient is analyzed or assessed on the scale of 100. On the first day of admission, the scale was absolutely lacking. The bowel was no control. Grooming, toilet use, feeding, transfer, mobility, dressing, stairs, everything was absent. And it was 10 out of 100. So on that scale, this is the Barthel index was 10 out of 100. So inability to carry out of the daily movements indicate the lack of the strength involvement of the 5 types of all the vatas. River-made mobility index is another index which is used again for checking the daily routines. Turning over the bed, lying to sitting, sitting balance, sitting to standing, standing unsupported, transfer, walking inside, stairs, walking outside, walking inside, picking up from off the floor, walking outside, bathing, up and down 4 steps and running are the 15 parameters on which it is checked, and it has the score only 0 and 1. You can see over here. Yes or no is the answer. So 0 or a score of 0. Last point. A score 0 indicates inability to perform the activities of the measure. So there is no in between score. So 0101 was is the measurement, and the score was absolutely 0 out of 15. She was unable to do anything on her own. She was not able to turning over bed in bed on her own also. Lying to sitting was not possible. Anything was not possible by her. So, and along with that, we also assess the patient on the scale of the spinal cord independence measure. This is the international norm, spinal cord independence measure. This is the 100 on the scale of 100. It's also the same parameters: feeding, bathing, then dressing, then grooming, and the scores are given like 0, 1, 2, 3 on the basis of the assessment. But it covers a lot of area like respiratory and sphincter management. Respiration and sphincter management is bladder. Sphincter management is a bladder, bowel. Then use of the toilet. This is the spine cord independence measure, and the second page is this. It checks the mobility of the patient, room and toilet, mobility in bed and action to prevent the pressure source, transfers on or bed to wheelchair or wheelchair to bed, lifting footrest and removing, transfers on from wheelchair to toilet or tub, then mobility indoors and outdoors or uneven surfaces, mobility indoors, mobility to moderate, mobility for the moderate distances 0 to 100 meters, mobility outdoors more than 100 meters, and stair management, transfers wheelchair, car, and transfers on ground wheelchair. So these are the parameters on which the patient is assessed. The spinal cord independence measure. The scale is generally used for the spinal cord deformities, but we generally use it for checking the patient who is having the problems regarding the mobility also. So this was the score in this patient, and you can see these are the dates: 3, 12, 23, 7, and 15. And the first box is for the 3rd of May, 1001114 6. The scales are like that here: 0, 3, 6, 9, 11, 13, 15. These are internationally approved scales, right? So on the first day, on the 3rd of the yes, the score was 18 out of 100, right? So the patient was having very poor mobility, very poor daily routine. And this is the grit test. Up to 50 on the sphygmomanometer, we raise and the pressure is raised up to 15 sphygmomanometer, and the by each hand, the patient is asked to press that bulb, and up to what level that gets upward, it is counted. So on the first day, right-sided, there was very weak, there was weakness on the right side, and on the left side, she was having some power that was up to 120. So this was the in general assessment of the disease. Then we assessed the patient also. The Prakriti was Pitta Vata. She was having a Sara of a Madhyam Sara by asking the previous history of the patient. Someone was Madhyam, Satmya, Sattva, Ahar Shakti, Vyam Shakti, and Vaya was all the parameters were Madhyam. Then we assessed the disease on the various aspects. It was the three doshas, Vata dominated. Gambira Avastha was there, involvement of the Oja was there, as Viveti Abhishnam Durbalo, Dhyati Vijitendriya is the Ojakshina Lakshana. So the patient was typically very debilitated, weak, and her life was on stake. So the involvement was up to Oja. That's why we consider it as a Gambira Dhatu, or Gambira Avastha of the, or Gambira Avastha of the Vyadi. Involvement of the number of dhatus, almost all the dhatus were involved typically Rasa, Rakta, Mamsa, Meda, the initial dhatus were more involved. The presence of Upadrava, weakness in all the four limbs, involvement of the whole body was there. As we all know, Guillain-Barré syndrome, in Guillain-Barré syndrome, slowly and slowly, the whole body gets covered. So involvement of almost all the body, the whole body was there. Now Jirna Avastha, so the patient, when patient arrived at Pakwas Hospital on 29th of April. So almost, and she started the problem on 3rd of April. So almost 3 weeks to 1 month was passed. So we regarding the Jwara Avastha, I cannot say it was a Nava Avastha, it was a Dirga Avastha or Dirga Kala Avastha. So it was a Jirna Avastha. Delayed treatment from Ayurveda, no Ati Kalam, Kriyapatham Atikrantam. All the three margas were involved. Sarva Marga Anusarina. So Autsuke Rati Sammoham, present Arati Sammoho in that patient. Indian Ashram, paresthesia and sensory loss was there. Tivra Dorbalya was there. So strength of the Hitus or strength of Purva Rupa and Rupa all were at their peak level. So modern diagnosis was demyelinating sensorimotor polyneuropathy with bulbar involvement, and the physician was having the GBS. So as we all know, so Guillain-Barré syndrome. Guillain-Barré syndrome is a rapid onset of muscle weakness caused by the immune system damaging the peripheral nervous system. Typically, both sides of this involves the whole body. Typically, both sided are involved, and initially changes in sensation or pain, often in the back due to the muscle weakness, beginning in the feet and the hands. I have seen a lot of Guillain-Barré syndrome patients. Sometimes these are the clinical pictures. Sometimes the patient comes with the absence of the fever also, with the weakness in the both the limbs. That time also you have to consider it as a Guillain-Barré syndrome. The basic condition is that it involves the lower limbs initially and upper limbs initially, and then it spreads to central thing. Right, the symptoms may develop over hours to weeks, a few weeks, and during acute phase, the disorders can be life-threatening, with about 15% of the patient developing weakness of the breathing muscles and therefore requiring the mechanical ventilation. That's why that SBC, single breath count, was suggested to that patient. Although the case is unknown, the cause is unknown, it is considered as an autoimmune disorder. It is related with the body's immune system, which attacks the peripheral nerves and damages the myelin sheath. Sometimes this immune dysfunction is triggered by the infection or by surgery or by vaccination. So she might, in this case, she might have got the trigger from the initial infection, which might be the abdominal infection. As per her, signs and symptoms are suggesting the temperature along with abdominal pain, nausea and vomiting was the episode, was the initial start. That time she was not having that weakness in lower limbs and all those. Those developed after 4 to 5 days of that episode. 2/3 of the people with Guillain-Barré syndrome have experienced an infection before the onset of the condition. Most commonly, the episodes of the gastroenteritis or a respiratory tract infection. Okay, so in those with severe weakness, prompt treatment with the IV immunoglobulins or plasmapheresis, both were suggested, and in fact they started the treatment also. Immunoglobulins were given to that patient, but despite of that, she didn't get any relief from that treatment. Demyelinating sensorimotor polyneuropathy was the complication of this Guillain-Barré syndrome. What is demyelinating sensorimotor polyneuropathy? Sensorimotor polyneuropathy is a body-wide process that damages nerve cells, nerve fibers, and nerve covering, especially myelin sheath. Damage to the covering of the nerve cell causes the nerve signals to slow or stop. We will see how it happens. Polyneuropathy is a peripheral neuropathy occurring in the same area on both the sides. So this is polyneuropathy, and upper expression was the sensorimotor polyneuropathy. So polyneuropathy is a damage or the disease affecting the peripheral nerves in roughly the same area on both the sides of the body, right? So it usually begins in the hands and feet and may progress to the arms and legs, and sometimes to other parts of the body where it may affect autonomic nervous system. Sometimes bowel and bladder are not routinely involved in these cases, but in some occasional cases, bowel and bladder also get affected. Just like this patient was having the bowel involvement. So this is the myelin sheath. What we were talking about. See, this is the nerve, and this is the myelin sheath. This is normal nerve, and this is damaged myelin sheath. You can see this is exposed nerve. The covering over the nerve gets exposed, gets damaged, and the nerve is exposed. What happens with that? With this red arrow, you can see the conduction of the impulses or the conduction of the senses pass fastly through this on the intact myelin sheath. This is nerve fiber, and the green color around that is the myelin sheath. But if it is damaged, scarred myelin, damaged nerve, this will halt the process of the transmission of the impulse from that nerve. This is the nerve ending. This is the ends. This is the nodes of the Renvir, red colored, and this is the myelin. This is blue color. So it gets damaged, and the nerve impulses cannot carry forward. So I consider there is dehe sotans riktani, purohitvani lobali. So these are the rikta sotas, or the sotas gets damaged due to the vata prakopa, or due to the various factors. And vata, the transmission of vata or the transmission of impulses through the vata cannot be carried on this rough surfaces. It provokes the vata again. So the demyelinating disease, in any demyelinating disease is any disease of the nervous system in which the myelin sheath of the neurons is damaged. This damage impairs the conduction of the signals in the affected nerves. In turn, the reduction of the conducting ability causes deficiency in sensation, movement, cognition, or other functions depending on which the nerves are in. So, this is the bulbar involvement. What is that? The isolated bulbar palsy is a rare regional variant of the Guillain-Barré syndrome. So the patient which we got was a rare type of the GBS. So it's a peripheral nervous system disease, including GBS. Okay. So now coming to the history of the patient. The patient was a domestic worker. She was having for almost 10 years or more. She was going to various houses for housekeeping, washing the utensils and washing the clothes. And she was having the work. She was actually having the on-field work. So Marutath Sevan was there, and irregular timings of diet was there. And it was typically, the diet was also not so nourishing. So the typical diet of the Vata Prakopa, which causes the Vata Prakopa, was there. So Samprapti Gatka, which might be involving in all this pathology, where the dosha, Vata, dominantly Vata, all the fighters of Vata were involved. As you see the Lakshanas, then Dhatu probably Rasa Rakta Mausmeda, Shukra, as I consider it as the symbol of the Dhairya. So it was lost over there. And in that patient, another aspect was that she was having amenorrhea also during that the whole period. So Dharto or Shukra was also affected, and Oja was obvious the obstruction. Oja was the obvious damage. Upadatu, रसास्तन्यम तथा रक्तमसृजा कंडरासिरा मांसदोसा त्वचा षट्च मेधसा स्नायु संभव. So kandara, sira, twacha, and snayu. We'll see these factors where they are coming in display. Jataragni was definitely involved, and Datvagni, no doubt, the Agni which requires for Aharasa to Aharasa should get into the Dhatus by the help of the Dhatvagni also, Dhatvagni only. So they were also diminished. Srotasa, Rasarakta, Mansa, Medova, Srotasa were probably most damaged parts. but Saudhnya was also damaged because Saudhnya should be carried by the Vata, and it was obviously damaged. All type of Saudhnya are considered over here. Marga, Trivida, Rogmarga, you can see Koshta, Shaka, Marmasti, Sandhi, all were affected. And Madhyama patient, the Bala was, when patient arrived, it was a Hina Bala, but the original strength of the patient was Madhyam Bala. So I will drag your attention to these three types of Vayu, Vatas, in this patient. Sthanam Pranasya Murdora Kanta Jiva Sanasika, Stivana Kshotudvara Shwasahara Karmacha, the respiratory involvement, and Stivana, the patient was continuously having this spitting, which was not able to hold the sputum in her mouth. That is the function of the Vata. Then Udanasya Puna Sthanam Navi Urakante Vacha, Vak Pravrutti, Prayatnoljo, Balavarnadi Karmacha. The patient the having the strength as the any strength of the patient comes from the Udan Vayu. And Devam Vapnoti Sarom Vyana Shigragati Nuna. Motor functions of all the body are the functions of the Vyana. Right? Sensations, Vagbata says, Pranotra Murdaga, Rudendriya Chittadrush, Rudendriya Chittadrush. Sorry, I got back. So, okay, leave it. So, sorry. Sthanam Pranas Murdora Kanta Jiva. So Indriya Druk is the function of the prana. The point was Indriya Druk was the function of the prana. So the sensations by the Sparshan Indriya are carried by the prana, and the motor functions, Gati Prasarana Akshepa, Nimeshadi Kriya. Nimeshadi Kriya can be considered or should be attached to the reflexes, and Gati Prasarana Akshepa to the motor functions. So prana and Vyana are basically related with the sensor and the motor functions of the body. Then process of Samprapti. These three factors should be considered while considering the Samprapti. Sa eva kupita dosha. So dosha prakopa, samuthana visheshaha, hetu vishesha, sthanantargatascha, sthana sonshaya, janayanti amayandu, where these are created. So tasmat vikara prakriti. Vikara prakriti is a samprapti gataka, dosha, dushya, and all those things. Adhishtanantaranicha. Adhishtana, in which srotasa or at what location they take as a sthan sonshaya. Samuthana visheshanischa budva karma samacharit. And samuthana is the hetu. So while considering the pathology of any disease, these are the three factors which should be considered for deciding the fate of the disease. So I am coming to the Vata Prakopa, Hetu and Samprapti. So this is the basic Hetu of the Vata. Ruksha Shital Palagvanna Vyavayati Prajagare. So the diet was it was not, she was not having good diet. She was having the diet which was having the lesser nourishment values. So Ruksha, Shita, Alpa, and Lagu. Anna was the primary diet. Then Langan was one of the factors which I consider. Adva, Vyayamati Vicheshtite, and Dhatunam Sankshat. These are the you can say Utpadak Hetu of the disease. Rogati Karshana, because this you see the Guillain-Barré syndrome is the disease which has the immunity relation. So the patients or the persons whose immunity is debilitated or the immunity is depleted are getting attacked by these autoimmune disorders earlier than other people. So these are the factors which might be the provocating factors for getting why the patient got affected by this autoimmune disorder. Dehe srotam siriktani puraitvani lobali karoti vidan vedin sarvangaikanga sanshaya. What happens in autoimmune disorders? Autoimmune disorders happens because some cells of the body attack the other cells of the body न जानते हुए गलती से, right? But they need the Kavaigunya for doing that, and this Kavaigunya is created by this Vata Prakopa Ketus, right? So Samprapti in general, the Samprapti is like hetu sevana. These are the utpadak hetus. The prerak or the prerak hetu might be that infection or that sudden attack of that temperature and all those. That was the prerak hetu. But initially the patient should have that khavai guna inside that inside the all the sotosad. So hetu sevana, as we discussed, vyavasay is prone to have this disease, provocation of vata dosha dominantly, then samsansha of vata in sarvanga, primarily in the snayu, peshi, sira, kandara of the shakhas, both upper limbs and lower limbs, through rasa and rakta. Dosha, dushya samurchana happens over there. Prokopit vata getting lodged in rasava and rakta sotasa and affecting this snayu, peshi, sira and kandara. The Vadi gets created. So temperature was there initially, and it was Veda, Vataj and Pittach type of Jwara might be there, and then it persisted. It didn't respond to the treatment, and the Upadrava of the disease happened through this demyelinating sensory motor polyneuropathy. So my primary, before coming to the diagnosis, final diagnosis, my various differential diagnosis include Chirna Jwara, then Vata Rakta, then Ardita, Snayugat Vata, Indriyagat Vata, Pakshavada, and Sarvanga Roga, right? So now coming to this Jwara. Why Jwara? Because the patient got affected due to this Jwara first. And as we all know that in any type of acute autoimmune disorder, Jwara is the first sign missing. So you can find all these signs and symptoms in the various types of Jwara. So this is the Vata Jwara, and you can see that there are the signs and symptoms. Padayoh Supta, you can see the sequence also. Padayoh Supta from lower to upward. Padayoh Suptatah Pindikayoh Udveshtanam Janunam Kevalanam cha Sandhinam Vishleshanam Urvo Sadaha. These are the typical signs and symptoms from in lower limb from extremity towards center. Kati Parshva Prushta Skanda Bhavansa Urasacha Bhagna Rudna Mrudita Matita Chatita Opatita Unnatam Eva. So these are the areas which got affected. Suptata was there, Pindikotveshtana was there, and Vishlesh was there, along with the high degree temperature in that patient. Along with that, he was having Shushka Chadi, nausea was there, and few episodes of vomiting were also there. I also consider as a Pitta Jwara, involvement of the Pitta Jwara also in that patient, just because the quickness of that disease and high grade and not responding to the init treatment. So, Atyartam Ushna Tivra Bhava, and Daha was there in that patient persisting after some time also. Why I'm considering not Jwara as Angina Jwara? Because initially the patient was having the Jwara for say, you can say 4th or 5th of April to 12th or 13th of April when she got admitted. But after that, the Acharka says, Ata Urdvam Kafe Mande Vata Pittottare Jware Paripakvashiti. So Charak considers Jwara becomes Jirna after 10 days by Kala Prabhav. Dashahat Parata Praya Kartavya Mahat ityadi. So the clinical condition inside the body remains like depletion in the kapha and increase in the vata pitta due to the ruksha guna of ruksha and ushna guna of the jwara. So this is the clinical condition inside the body of that patient after 10 days. Why it is important? Because both the ruksha and ushna gun are having penetrating and damaging effects. So if the jwara persists or if it is not getting treated and if it gets leaner in the dhatus, it slowly starts damaging the various dhatus inside the body, and the preventing factor of a body, that is kapha, becomes gets depleted due to the kala prabhava in jwara. Another differential diagnosis of mine is the vata rakta, just because the pattern of that disease. तस्य स्थानं करो पादौ अंगुल्यः सर्वसंदेयः कृत्वा आदौ हस्तपादेतु मूलं देहे विदधति. So कृत्वा आदौ हस्तपादेतु is the typical sign or typical way of the GBS. Sokshmat, and then it's a very important sutra which comes after that. This Sokshmat sarvasaratvacha paunasya sujatata tadravatvat sartvacha dehem gachan sirayane parvasu abhihatam shubdam vakratvat autishtate sitam pittadi sansushtam tastas vidati vedana. So Sokshmat sarvasaratvacha paunasya sujatata. Pavan and asuj are the two factors which are having Sokshma and Saragun, which travels throughout the body and spreads the disease from the periphery to the center part. Karoti dukkam teshu eva tasmat prayan sandesh. But why I excluded this and not why Jirnajvara was excluded, not as when it comes to the clinic, I couldn't treat only Jirnajvara. I was unable to because the patient was having a lot of other complications also. So Jirnajvara as a final diagnosis was excluded. Then Vatarakta was also excluded because the involvement of Sandhi is more in Vatarakta than this particular condition. So Vatarakta was also ruled out. Though the signs and symptoms, Sparshadnyatvam, you can see the 16th sutra, Sparshadnyatvam Chateti Rup, Tivra Vedna, the patient was having severe pain. But the other factors which were absent in that patient ruled out that possibility of the Vatarakta, right? Then Snayugat Vata. Bahyabhyantaram ayamam khalli kubjatumev cha sarvanga ekanga rogasya pura snayugatana. Involvement was the sarvanga roga. Involvement of sarvanga roga is also happens to be in the snayugatanila. But along with this snayugat, but in snayugat vata, the signs and symptoms are related only. They mimic more likely ayama and kalli kubja. So we just consider it as one part, but not as whole diagnosis. Then indriyagat vata, the sparshan in the involvement of the sparshan indriya also was there. So I considered regarding the indriyagat vata also, but as a whole diagnosis, it was not possible to go for the indriyagat vata. Then ardita, as I said earlier, the patient was having the loss of the wrinkles, smile was absent, and she was having Steven, and puffing was, she was unable to put the puff. So we thought about the ardita also, but ativruddha sharirardham ekam vayu prapadyate yada tadopashasya asrubahum padam janucham bahum padam cha janucha. So the involvement of bahu, pada, and mukha pradesh tasmin sankocheti ardhe mukham jimmam karoti cha. But typically ardita involves only half part of the body or half part of the mukha, which was absent in this case. So ardita was also ruled out. In though in the last line ardhe tasmin mukhar deva kevale satadarditam, Charka says va ardhe tasmin mukhar deva kevale. So hastapad ardha or mukharda, but there was no such condition, so it was also excluded. Then we came to the pakshavada, hatvaikam maruta paksham dakshinam meva. You can see the patient was areflexia was there, and paksha, both the lower limbs and upper limbs were not functioning in a proper way. So both the paksha were chesta nivrutti was there, and sirasnaya vishushacha padam sankocheti ekam hastam va todashulupu. Todashul was there. Hasta and Pada were also involved in this case. So if that is the case, then it is called as Ekangro. But what Charka says on the dotted line is very important. Sarvangam Sarvadeha. So in Sarvangaruga is a different condition which is explained in the Pakshavad. So I always consider various neuromuscular disorders which involves specifically polyneuropathies or various type of musculoskeletal neuromuscular disorders in which we find that chesta nivrutti, like myopathy and all the other things in which sira, snayu are involved. What I was saying since the beginning of this lecture, involvement of the sira, snayu or kandara in the neurological conditions and having the half part or full part. Sarvangam Sarvadeja. This is typical clinical condition in which the patient got the whole body of the patient got involved. So I came to this diagnosis as a Sarvanga Roga, right? So, but before that, coming to this diagnosis, I will drag your attention to the definition of Upadrava. उपद्रवस्तु खलु रोगोत्तर कालजो रोगाश्रयो रोग एव स्थूल अनुर्वा रोगात् पश्चात् जायते इति उपद्रव संज्ञा तत्र प्रधान व्याधि व्याधि गुणभूत उपद्रव तस्य प्राय प्रधान प्रशमे भवति. सो रोगोत्तर कालजो रोगाश्रयो रोग एव. Upadrava is a separate clinical condition or disease itself, separate disease itself arising as a complication of the main disease. The roots of the complications arise from the main disease itself. So the complication of the condition of the demyelinating sensorimotor polyneuropathy arises from the Guillain-Barré syndrome as a complication. And it's a separate entity. Guillain-Barré syndrome is a separate one. You cannot treat, you can not do plasmapheresis or just supply of the immunoglobulins to cure the polyneuropathy. It will not solve the problem. It solves the problem of the Guillain-Barré syndrome, but it doesn't solve the problem of the sensorimotor polyneuropathy. So it's a separate disease itself, and it has separate entity. But if it is creating more pain than the main disease due to the complex nature of the pathology and weak body, it should be treated quickly or should be attended primarily. So Upadrava should be attended primarily. So my final diagnosis was Sarvanga Roga. As I said earlier, it is not Ekanga Roga, it is a Sarvanga Roga as Upadrava of the Jirna Jwara, Jwarajanya Vata Prakopa. Vata Pitta Jwara giving extending for more than 10 days, leading to the Vata Prokop, damaging the myelin sheath of the nerves and creating Sarvanga Roga as Upadrava. So demyelinating sensorimotor polyneuropathy as a complication of the Guillain-Barré syndrome is my final diagnosis in this case. So the treatment, aim of the treatment was to treat the Neuropathy. Okay. Now coming to the Vata Prakopa. Which type of Vata Prakopa it was? It was typically Neuropathy Vata Prakopa, because the hetus or the samprapti doesn't suggest this type of pathology which happens in the Upastambhit Vata Prakopa. So damage of the myelin sheath over the nerve is a typical Dhatukshaya, indicates the Dhatukshaya in that particular area and where the Vata gets lodged. So this is Nirupastambhit Vata, which is spreading all over the body, depleting immunity and reducing the strength of the Dhatus and Oja. So objectives were to control or regulate Prakopa and pressure of the fast spreading Vata, to establish strength of the Dhatu and Oja, to establish the strength of the involved Upadhatu and other organs, to establish the normal functioning of Vatadi doshas and all the other involved Rasadi Dhatus along with the Siradi Upadhatu. So my primary aim was to control the provocated Vata dosha, and along with that main objective, various other things also should be established during the treatment. So methodology, principles, by what principles or on the basis of which principles I can get these results. So the dravyas or the measures which I will be using should be having the properties like Snigdha, Guru, Ushna, Mrudu, Sthira, Manda and Shrakshna, which will help in establishing, in developing the regeneration of that nerve, number one. Helping the depletion, helping in fulfilling the depletion of the Rasadi Dhatus and pacifying the Vata. And that's why, as the Charaka says, there is no other treatment modality available than the Shadvidupakrama. Snehana, Rukshana, Svedana, Stambhana, Langana and Bruvana are the fundamental treatment modalities used in any type of medical practice. I'm saying any type of medical practice. So out of these 6 modalities, 3 should be chosen, as Snehana, Bruvana and Svedana should be carried out in this patient. So modules to be used: condition, dosha quantification, Bahudosha Avastha, site of the dosha spread all over the body, especially in Urdhva Shaka and other Shaka. Urdhva Shaka and Adha Shaka. Urdhva Shaka, Hasta and Bahu, Adha Shaka, Uru and Pada. Vikalpa of the Chikitsa, Bodoshavasta, Vata Prakopa, and Nirama condition or Alpasama condition when the patient came to the. So textual guidelines which were used for were the extracts from the Jirnajwar Chikitsa were used. Nirupastambit Vata Chikitsa was considered. Bahugata Vata and Adonabhigata Vata and Sarangat Vata. These are the three Vishesh. Samanya Vata Chikitsa is explained in the Nirupastambit Vata Chikitsa, but the Vishesh Vata Chikitsa is explained in the other Gatvata and Aurtvata treatment. So out of that, Bahugata Vata, Adonabhigata Vata, and Sarangat Vata Chikitsa principles were used for the treating this patient. So Jirnajwara Chikitsa, you can see the Jirnajwara Chikitsa. Ata urdhvam kape mande vata pittottarejvare paripakveshi doshishu sarpish panam yatamrutam. Okay. The patient, when the patient came at our OPD or at our hospital, was having severe Kshudamandu. So initially, she was unable to have, she was having the RT also there, the RT was also there. And Paripakveshu dosheshu sarpish panam yatamrutam. Sarpish pan is suggested in these patients after 10 days. But in that patient, initially it was not possible. After some period, we started a simple Gogrutha as a diet article for that patient after 10 days of admission when she got getting the results. Then use of Virechana, Kriyabi Prashanayati, Prayati Yada Jwara, Akshinabala Mounsagane, Chametam Virechane. But she was having Shinabala and Mounsa and Agni. So Virechana was initially avoided. Jwarakshinasya Hitam Vamnam Virechanam, Kamam to Paisatasya, Niroherva Retmala. This modalities we used in this patient. Niro Balam Agnimcha Vichvaratam Mudamruchi. So what Niro does in these patients, so Niroha increases the Agni, increases the strength, and reduces, helps in reducing the Lina dosha by removing them out, expelling them out. Paripekvishi dosheshu prayuta shigramave. Then Pittamva Kapa Pittamva Pittashegatam Hareta, Sronsanava Tinmalam Bastir, Haret Pakwashita. If the doshas are getting located in the Pakwashaya, those should be removed from the Sronsan Chikitsa. And then Pradaddat Anuvasanam, Anuvasan Basti should be Jware Purane, should be used. Nasa is also suggested Gaurava Shirsa Shuda, Vibhaddhishwendri Yushta, Jirna Jware Ruchikaram, Kuryat Murta Virechana. So in this Jirnajwara condition, Vibhaddheshwendri issue, as I said, Sparshanendriyas happen and Karmendriya are also getting damaged. So Nasa is also suggested in these patients. And Abhyanga Parishaka, Abhyangascha Pradehascha Parishaka Gahane, Vibhajya Shitoshna Krutam Kura Jirna Jware Bishak. So this is the line of treatment, Panchakam line of treatment explained in the Jirnajwara. And while treating the patients, we keep this in mind. Nirupastambitva Chikitsa, everybody is aware of this Chikitsa. Kevalam Nirupastamba Madhav Sneha Upacha. So it should be Sneha and Swedan only in the initial stages. So last line of this, Navanai Starpanishannai, Susnigdam Svedata Kata. Payase Kushare Samla Lavani Anuvasan and Navanasya are the drug, treatment modalities which are chosen over the other treatment modalities. And Svedana, various types of Svedana are suggested to that patient. What happens? So Sneha and Sneha Mrudo Koshtena Tishtantini, repeated use of Sneha and Svedana helps in pacifying the Vata. So these are the three line of treatment explained in the Vatvedi. Bahu Shirshagate Nasem Panam Chautarvatim. As I said, the involvement of the Bahu and the involvement of the Pada Pradesh, Adonabhigata Vata, Adonabi Pradesh, Basti Karma to Adonabi, Shasete Chaupedaka. Generally, we consider Adonabhigata Vata Aupidak. When we read Aupidax, we always consider it is of the treatment of the Basti or related disorders. But Adonabhigata Vata is Adonabhigata Vata. Anywhere, if Vata is getting located in Adonabi Pradesh, should be treated with the Basti Karma. And Sarvanga Kupita Vata, Sarvanga Kupite Abhyango, Bastaya Sanvasana. So Abhyanga Basti with Anuvasana is the line of treatment which should be considered in this patient. So Abhyanga, Svedana, Basti and Nasya were the line of treatment along with the few sessions of the as the patient was debilitated, it was not possible for her to bear the stress of the physiotherapy also. So initially she was suggested to undergo the physiotherapy, but she refused to. Already she was getting physiotherapy for 15 days in GMC. She refused here, and she didn't go for physiotherapy very routinely, though we were suggesting. But the Abhyanga Svedan Bastanasya was the primary line of treatment. So Basti Anuvasana was the primary line of treatment. So Charatil, we started in this patient. So Charatil 60 ml plus Charatil 60 ml. So Charatil is having the Ushna property, and it is good Vata Shamat. So I chose that instead of other yeah. Initially, when the patient came, Neuro was supposed to give because the patient didn't pass the Mala for 2 days. But as the strength of the patient was, I was not aware of the strength of the patient. So initially, we went for the Anuvasana only. And then after on the next day, she was given Irandamula Nirva, followed by on the same day, in the evening, we gave the Anuvasana. Then again on the next day, Anuvasana. Then again, Nirva, Anuvasana. On the 5th day, Nirva, on the same day, Anuvasana, and then 5 Anuvasana and 1 Nirva was the sequence which I kept throughout the treatment, throughout the line of treatment. So total Anuvasana were given almost 32, and total Nirva were given 8. So total 40 bastis were administered in the patient. So Nirva basti, Mala was not passed on the second day. So Nirva was planned on the alternate day for the next 6 days in the early period. But as Nirva leads to the expulsion of the doshas or the expulsion of Malamutra. And as we know that in Shoshi patient or in debilitated patient, Mala should also be conserved to hold the strength back, as said in Yakshma Chikitsa. So in this patient, we avoided Nirva. Just Nirva was given after 5 days. So, hello. So, so Niro was given in a very lesser quantity. So Niro Basti, Iranmula Nirva was chosen from Charak Chikitsa 3. This is the sutra. We have this our outlet where we have prepared this Iranmula Nirva. We keep the Iranmula Nirva Barad and Apushadi Kalka, which is Shatavadi Kalka, explained in the Iranmula Nirva Kasha. We use 400 around 400 ml to 500 ml of kashaya, 80 grams of Shatavadi Kalka, 80 grams of Madhu, and 80 grams of Tila Tela in this patient, and send over 10 grams. This is a routine practice in our hospital. We generally give this much of quantity approximately in every patient. Then these are the Neuropathy paper and Anuvasana paper, which we maintain day 1, day 2, day 3. You can see days. This is a Bhukta and Bhukta, Basti Dan Kal, Basti Pratyagam Kal, then Basti Pashat Mala Pravrutti, Basti Pashat Mutra Pravrutti, Basti Pashat Apana Pravrutti, Bhojan, Ruchi, Nidra Surup, and all the details of the patient. You can see day 4, day 5, day 6, and day 7. So this is the Basti paper. This is just, I have given the sample of these 2 papers, but these are the treatment modalities we generally use, and documentation is likewise. The Nasya, type of Nasya, Nava Nasya was suggested. Baladatra Tela was drug of choice in this patient. 3 ml in each nostril. Actually, I use in all the neurological cases. Generally, Baladatra Tel. We have worked on that. And Urdhva area or Urdhva Pradesh, I was considering as Urdhva Pradesh. I was planning Nasya in the patient as Bahugata Vata, for the Bahugata Vata or Urdhvagat Vata. Ushtasmanta Chinchiman was there, Nishtivan was there. So I was scaring that she might have that upward direction, and she might that might reach faster. So to prevent that, I was planning this Nasya. So 3 ml in each nostril, that is 6 bindu. 0.5 ml is equal to 1 bindu. We routinely practice as a 3 ml in each nostril as the starting dose of the Nasya, not drops. I repeat it, it is not 3 drops, it's a 3 ml. Okay, 1 drop is 0.05 ml, and one bindu is 0.5 ml. So it is almost 10 times of the drops, simple drop, simple dropper. So when, if you are using the dropper at least 10 drops or 20 drops. 10 drops is a 1 bindu, 20 drops is a 2 bindu. We started as a hina matra of the Navan Nasya with 3 ml of the Nasya in each nostril. 37 sessions were given. Nasya was continuously given in the afternoon or in the evening time, and throughout the period it was going on. All the panchakarmas in our hospital were having the were not carried out on the Sundays, as the hospital is closed on that day. So automatically the gap day was getting maintained during the whole period. So Anuvasana or Niruha or Anasya, Ati Yog of any Panchakarma was avoided that way also. Okay. So this is the Nasya paper which was maintained initially, and then Socharatel was used in further course. Okay. So now coming to the medicine part, as we are 4:40 now. So the medicine which I used in as the patient was having patient was weak, Bahudoshavastha. So we started with the loading doses of the Rasraj Rasa, Mahayuraj Google and Rudrok Chintamani. Along with that, Amrututtar Kashaya, Vishnindukoti, Arogyavardhini, and Nishuttar, the combination of the Nishuttar, Triphala, and Aragvada Majja after some days. This was started. The medicine were started in a loading dose. Rasraj Rasa, initially it was 1 TDS, then I increased that dose to 2 BD for 15 days almost, and then we again tapered it up to 1 TDS, but it was always in a high dose. Rasraj Ras, as everybody knows, that it is having Abrak, Swarna, Loha, Rajata, and Vangavasma. All are very important dhatus metals. Then Mahavraj Gugul was also used as a Rasayan Chikitsa. It was also having in Vatvedi as Gugula is having good role. So 2 taps BD and Rudrok Chintamani was also used in this patient. Rudrok Chintamani is a patent drug from one company. 1 tablet TDS. I will discuss about Rudrok Chintamani later on. So it is having Akika, Arjuna, Jatamansi, Manjishta, Abrak Basma, along with the Purna Chandrodaya Mukadwaj, and it is also having Jahar Mohra and Jahar Mohra Pishti also in this. Then Amrutottar Kasha was used to the combination of Adraka, Guduchi, and Haridaki. It is the Jwara Vadi Pratyani. Then Arogyavardhini, as it was also used in this patient, 2 BD was the dose, and Vishindukwati in the dose of 2 TDS. And the combination of the Nishutta, Triphala, and Aragvada was after 8 to 10 days when the patient got some strength, we started this as a routine anuloma. Gogruta was advised to the patient throughout the stay through the food. So Upashaya relief. So the patient started getting relief on the 3rd of pain, slightly 5. When she got admitted, within 4 days, she started getting relief in her pain. Then holding on started of holding the toothbrush for the brushing started on the 3rd May itself. Then good relief of pain on the 6th day. Then 6th May. Constipation on 5th May, and sphincter control started to be in proper place. So she started saying that she can have that sensation now. And then sitting balance started improving on 8th May. Then Oshtochimchimine relief started on 11th May. Started sitting in the bed with the support of 11th May. Then ability to form the wrinkles and ability to create puff and smiling was present on the 12th May. These are the 3rd May. The patient trying to brush the teeth was not able to hold the brush, and this was started developing during this on the 3rd of May. Then grooming of the patient on her own started 13th May, combing her hair on her own. Then pain relief 15%, 50% was there after 15 days of the treatment, 14th May. Was 6 and PRS 3. Initially, visual analog scale was 7 and 3, but was still was 6 and PRS was 3. But the patient herself was saying that she got good relief. Started squatting in sitting position on 15th May. She was able to sit. Started to getting up from the sitting position with difficulty with support on 18th May. Started sitting in bed on her own 19th May. Started walking with support for about 5 minutes 20th May. Pain relief was 4, PRS to 60%. Patient status was the visual analog scale and pain rating scale is the PRS. Patient started eating chapati on her own 13th 5. Patient pain relief 70%, 18, 28, 5, 19. This is Baladatratil, and this is 100% relief in Ostochimchimayan and Astapadada. On the date was 6 June. Okay. Bowel holding capacity increased up to 5 minutes. She was able to hold the bladder, bowel. Initially, when the urge was there, she had to rush to the bowel for the bowels immediately. But after 1 month, she started holding. She had that ability. She specifically mentioned that she had that ability to hold the bowels for now 5 minutes. Complete pain relief in Hastapadata Chimchimayan on 6th of 6/6/19. Can climb stairs on her own on 10th June. Then Brahma relief 90% on 14th. Kati Pushta Shula 15th of May. These are the spinal cord independence measure. As I said earlier, out of 100, initially was 18. Then on 12th of May for 24. On 23rd of May 58. Then on 7th of June 89. And on 15th of June, it was 92. Then sensory examination within 15 days, or within 10 days, in fact, all the senses came back. That loss of sensation in the upper right, upper hip was also regained. And Barthel index on the 0, 5, 10 on the scale of 100, on the 8th, it was 20. On the 15th of I will tell you. On 15th of May, she got some bladder control. Then grooming started, which was with the support on the with support. That's why the score was 5. Then dressing started. That was the 5. So 15th it was 25. Then on 7th of June. 23rd of May, it was 50, right? So she started having the bowel control, bladder control completely. Grooming, she started on her own. Toilet use started on her own. Feeding was on her own. Transfer on her own. Mobility was achieved with the assistance. Transfer with assistance. Feeding with assistance. Toilet use with use. Then dressing was with assistance on the 23rd of May, and on the last day she was able to do all the things on her own. So the score was 10 out of 10 for every parameter. And the Rivermed index, turning over bed, lying to sitting balance, initially absolutely it was 0. On 10th, on 8th, she started doing turning over bed was started, and yes, and lying to sitting straight, right? Then on 8th of May, turning over bed. 15th of May. 15th of May, turning over bed, lying to sitting balance was started developing. And then 10th, 7th of June, she started turning over bed was okay, lying to sitting was okay, sitting balance was okay, standing with support was there, transfer with support was there, walking with aid was there. So, and on the last day, only picking up from the floor was absent. Bathing was not possible on her own, and running was not possible on her own. These three parameters were missing. Otherwise, Rivermed was also achieved completely. So, possible why we choose this type of line of treatment, possible action of the drug. Anuvasan was extensive use. It provided the much needed snare to the body, might also help in regeneration of the mildly damaged cells. Snehshcha datun sansushtan, Ushnate ashu prayojita, balam agni balam pushtim, pranacha pivardayet. Then Bing and Svedana might have helped when pacifying vata spread throughout the body by improving the circulation and nourishing the cells of the body and also helping in reducing the pain in the body. Harshatodurugayama Shotastambhagrahadaya Svinasya Prashamanti Mardam Chopajayate. Nasya might have helped in controlling the prana and vyana through its action over the upper part of the body. Rasraja Rasa is very well known for its efficacy over the Snayu Kandara and tissues. It helps quickly in pacifying Snayu Kandara Maunsagat Vata than any other drug. When used along with the Vichindukwati, it controls and regulates Vata with its Ushna property and also works as a Rasan also. Rudrak Chintamani was used for various reasons. Jatamansi, Jarmora combination along with the Abrak Basma controls and regulates Sadhya Vaha and Manosotas. She was having Nidra Nasha during the initial period. Which was also significant, but as the days passed on, her Nidranasha complaint was solved. Brutva Chintamani is used in a very less quantity in this Rudrak Chintamani. It controls Vata, specifically Sarangat Vata, better than any other kalpa. Then Mahavraj Gugul was used for the Rasayana and Vata property, and Arogyavadini is known for the Jirna Jwara, Amrutarkashan as a Jwara Pratyanik Pratyanik along with its known Pachana function was used. And so the conclusion and the summary, demyelinating sensory motor polyneuropathy can be treated successfully by Ayurveda treatment. Anuvasan Basti plays a major role in controlling the disease. In this particular disease, Nasya helps in regaining the power in the upper part of the body, and Suvarna Kalpasol should be used in the Durbal patient to support the Panchakarma treatment routinely. Thank you. Thank you very much. One sec. I would like to share one video of the patient. This is the patient. This is the same. See the patient after some period. So this is the same patient. So thank you all for listening to me. Thank you, ma'am.
Thank you very much for presenting such a wonderful, successful clinical case with the ultimate documentation from the day one. And you have presented with all the scales, neurological scales for the deficits, neurological deficits in the patient, along with a description for the differential diagnosis and even the selection of medicines and the treatment. Thank you very much, sir. So we have some questions from our students.
Yes.
So is the Nasya is given along with the Basti? Like it is said that the Sneha should not be used in both the roots together at once, like both Nasya and Basti.
Yes, actually, it is a very oftenly discussed point that Nasya and Basti should not be used in the same at the same time. But what happens if you go through this Nirupastambhit Vata Chikitsa, Charka has suggested to infuse the patient with all with the sneha through all the routes as possible. So it should not be rule. And when I use Nasya, I again uh, I, I give the patient Nasya in the evening, not in the morning. We just give the
Because it is
patient because these two are the different areas or different margas located situated away from each other. So if you are doing something in a region, you should not do in the upper part. It is the basic thinking. So both margas should not be used at the same time.
Can it be taken, sir? Actually, can it be taken like both routes, that is Pana and Basti?
It can be taken
rather than Nasya and.
It could have been taken, but as it is having some sparshan indriya, I was thinking of prana involvement, and I thought that prana should be treated because it's a sensory motor. See, it's a sensory motor polyneuropathy, and to go through that prana, I was thinking of this nasya, number one. Number two, as I said earlier, Krutapana was being suggested to the patient through the food, because initially she was having Tivra Kshuddhamanda. So there were very few ways were available for me to infuse sneha to that patient. To give to that patient. So these are the two routes which were available. So I keep the distance. I generally give this nasa in the evening time. If at all, I think that sneha should be given in the patient through as many route as possible. Then I use these two ways with the two.
Actually, one more question is like maximum of 21 days this Navaranasya can like. So
That's
apart from Pratimarshanasya, Navaranasya maximum 21 days, even with some gap, Acharyas have told to administer.
Okay.
Like it was done for like 37 days continuous.
Yes. First thing, 21 days is the general rule. But if doshas are there in a much more larger quantities, number one. Number two, with the gap, what it should not be. Why these indications? Why these things are explained? Just to avoid the ati yoga of the patient. When you go for this line of treatment, you should always check the signs and symptoms. When I suggest that I give the Anuvasan Basti for 9 days, 11 days, 5 days, 7 days, I always keep an eye over the Kshuddha. What is the status of the Kshuddha? So generally, when I go for Basti or Nasya extensively for longer periods, I always keep an eye on the signs and symptoms of the patient. If I'm not finding Ati Yoga of the Snehana, so that means Sneha can be given in a more quantity. So we just generally continue the patient with the Sneha.
Same way, I have received one more question, like even about the Basti also. Even 40 days, it was given with a gap of 5 days Anuvasana with one Niruha.
Okay.
Schedule, about the schedule.
Yeah, I know. That's why I specifically mentioned those numbers. I knew that these are the routine questions which are arised in this discussion. Number one, see this Yoga Basti, Kala Basti, and Karma Basti, the schedules which are given are just the symbolic ones. They are there to explain you the way of administration. Depending on the quantity of the doshas, you have to decide the number of the bastis. Sometimes we give the 13 bastis also, sometimes we administer 9 bastis also, sometimes we go for 18 bastis also, sometimes we go for 25 bastis also. So it is never, and it is not mentioned anywhere that one should not go beyond 30 bastis. It is not mentioned anywhere. You have to decide the quantity of the doshas, and accordingly you have to give the number of the bastis in the patient.
That is why this title of the webinar, like Yukti, holds good.
It's a Yukti.
Yes.
Because समीक्षानी ही दोष भेषज देश काल बल सात्म्य सत्व आहार वयतःश्च अवस्थाश्च पृथग्विधा Charka says. So while treating any disease or any panchakarma, any disease through panchakarma way, one has to follow the quantity of the dosha, because matra kalo vicharyan, these two things you cannot avoid while dealing with the patients through panchakarma way.
Thank you, sir. Last question, like what is a rationality behind the selection of Aragbuda Majja Kashaya in this case with the Nishottara Triphala?
Basically, it's a routine I use. This is the combination to
For
for Anulomana. All the three doshas are covered through all this mixture. And only I tried in the single way also, Triphala or Shuttar or Draksha or Argod also. But if you use any single of this, it creates non-palatability. It nauseates the patient. So the taste, or you can say the combination which covers all the three doshas, helps me in getting the regular Anulom in the patients. And it is cost effective also.
Sir, thank you. Thank you very much that you have elaborately explained without leaving a single part in the presentation. Excellent for on the part of the scales, all the skills with the scores. It is very essential for our PG scholars. You have delighted the PG scholars and in the documentation of the case, and even about differential diagnosis and all.
Documentation, how we maintain these papers. Show this. This is the case paper of the patient through which I extracted all the things. One sec. Why it is important? These are the papers actually. I will show you this is PRPP. This is Panchakarma Rugna Parikshan Patrak.
Yes.
This is the demography. And actually, Samikshani Dosha, Charak Sutrastan 15/5. Where Charka explains Desha, Dosha, Kala, then Sattva, Dehabala, Akruti, Vaya, then Koshta, right? So these are the lakshanas, the Shavasta lakshanas are there.
So thank you, sir. Thank you very much for clarifying all our doubts. And it shows your in-depth knowledge regarding the diagnosis, differential diagnosis, and even the selection of the treatment and even treatment protocols. We are fortunate enough to have your talk in this YUKTI 21-22 series, sir. So on behalf of Department of the Panchakarma and from our JSS Ayurveda Medical College and Hospital, Mysore, I once again thank you for your presentation. Thank you, sir.
Thank you, madam, and thank you all. Thank you. Thank you.
Thank you.